Okay, so the problem statement is in the real world, NSCLC has worse prognosis. 30 to 40% of NSCLC are PS2 and PS3. No consensus guidelines for the treatment of that. PS is a major indication of tolerability and response to cancer treatment, and poor PS more likely to be affected by the treatment-related toxicity, quality of life, detrimental status, and limited OS PFS benefit. So there were previous article like one or two good responses, like this is a Lazarus type response of immunotherapy in 3 patients. This is a Chinese article. Then there is this one, immunotherapy outcomes in individual with NSCLC with poor performance status. And both these articles and all evidences, they suggest that whenever there is a PD-L1 status more than 50%, then the responses we can use in PS2 or PS3 responses are good. So this is just a case that we are not going to in detail, but this is a stage 4 NSCLC with low PD-L1 expression and ECOG performance status 2. Here the problem comes. Already Sir has already explained us that is PD-L1 is not the only biomarker. We have many other biomarkers that we'll use in the future. But now what in this case? So there are some trials I just want to mention quickly. Phase 2 Checkmate 171 nivolumab trial, which is for adverse event OS safety trial. And here I can just show you the all treated patient with nivolumab. The median OS is 10. And here out of this, more than 70 also OS is good, more than 75 good. Only in case of PS2, it was just 5.2. This is one more trial with the pembrolizumab, benefit with the patient with the ECOG performance status 2. Here we can see PFS 4.4 and OS 9.8. And here durable clinical benefit, the chart is clearly indicates that it depends on PD-L1 expression. So now I just want to mention one more trial that gives answer to few more our doubts. This is IPSOS, what they called. This is a trial which is a phase 3 global multicentral open label randomized control study which examining the efficacy, safety and patient reported outcomes with atezolizumab versus single agent chemotherapy in a patient with were considered unsuitable for first line platinum doublet chemotherapy. Sir has already mentioned that why atezolizumab was not useful, they don't know. And I also don't know, but here this trial I found that it was useful. Definitely we should but main important thing is this is comparison with a single agent chemotherapy in patient with PS2 and PS3. And this is a trial design where they included squamous or non-squamous histology, PS2, PS3 and PS01, which they are permitted only if they are more than 70 years of age with substantial comorbidities, and EGFR and ALK excluded. So atezolizumab versus the chemotherapy, they used vinorelbine and gemcitabine. Here is a primary endpoint OS, which shows that the atezolizumab single agent 10.3 versus 9.2 with HR 0.78 and P significant. Here we can see the separation of curve here. Here is a subgroup analysis, and this is a PFS chart which also shows that 4.2 versus 4, there is a separation of curves. And the more important is overall response rate. So here we can see the significant difference that overall response rate in atezolizumab is definitely more than double than that chemotherapy, which is 7.9 in the chemotherapy with atezolizumab 16.9. And here we can also see there are CR atezolizumab which shows 4 CRs as well, which is not seen in the chemotherapy. The more important thing in the PS2, PS3 people is the quality of life. So health related quality of life, patient reported outcomes here is atezolizumab arm remains stable across all domains while chemotherapy arm showed some deterioration. Here the comparison of role function, social function and cognitive function is there. So the same slide, and this is so we can see the health related quality of life. Few more slides. Improvement in atezolizumab arm was seen for symptoms of cough and chest pain, and deterioration of in chemotherapy arm was seen in peripheral neuropathy and alopecia. Improvement in chemotherapy arm with insomnia, and improvement in atezolizumab arm and deterioration in chemotherapy arm in appetite loss. So definitely, as we can expect the better quality of life with immunotherapy. And this is a time to confirm deterioration, and which is also showing favorable response. So the conclusion of this trial was first line atezolizumab significantly improved OS over third generation single agent chemotherapy in the patient with NSCLC ineligible to receive platinum doublet chemotherapy regardless of histology, regardless of PD-L1 expression, and regardless of ECOG performance status. And 2-year OS nearly double with atezolizumab, 24.3 versus 12.4. Overall response rate was higher with atezolizumab with durable responses 14 versus 7.8 months. It was associated with stabilization of health-related quality of life functioning domains and significant improvement in time to deterioration of chest pain versus chemotherapy. No new unexpected adverse events were identified with atezolizumab in the study population, and treatment-related grade 3-4 events occurred in smaller population, patient receiving atezolizumab versus chemotherapy. And this was the first randomized study to show first-line treatment with atezolizumab, which improved OS in poor prognosis and SCLC population with no EGFR alteration regardless of histology and PD-L1 status and ECOG status. And no new safety signals were identified. So what is the conclusion? Definitely in PD-L1 high patient, the single agent immunotherapy OS PFS is better than chemo or best supportive care. And even in a PD-L1 low patients, first-line immunotherapy improves OS over single-agent chemotherapy, which is in a patient who is ineligible to receive platinum doublet chemotherapy regardless of histology, PD-L1 expression, and ECOG performance status with better quality of life. Thank you very much.